Hi, this is Terry Kuti. Welcome to the Deep Sea Foundation channel, where we talk about all options and topics related to breast reconstruction for those affected by breast cancer. And I'm joined today by a very special guest. His name is Dr. Steve Pisano. He's a board-certified plastic surgeon who is a specially trained microsurgeon, and he works with an amazing group of microsurgeons in San Antonio at a group called PRMA, Plastic Reconstructive Microsurgical Associates. And I have to add, Dr. Pisano, that you guys have reached the milestone of 9,000 autologous flaps, which is pretty impressive.
Thank you. Yeah, thank you very much. That milestone occurred, I don't know, a couple of Tuesdays. It was like a Tuesday, and I found out because I was looking at Facebook and reading Deep Sea and so forth, and Courtney probably posted that, our media person, and that's how I learned about that. So there was little fanfare because we're coming out of the COVID thing, and ordinarily we probably would have had some sort of celebration, but thank you for acknowledging that. That was 9,000 of anything is a lot. So.
Oh my goodness. It is a tremendous accomplishment. And I know you guys have really been kind of working a little bit of overtime trying to catch up with the surgeries that were canceled during COVID, or they were on hold, I should say. They were on hold to be rescheduled. And so I know that you guys have really been putting in the extra hours and working hard to.
Yeah. August was a busy month. I just spoke with our practice administrator, Sharon Lacey Supik. She said we did 75 individual autologous tissue transfers, mostly deep flaps, in August. So 75 in 1 month is pretty stout. So things are back to normal in that regard. So that's a good thing.
Yeah. Yeah. And today you told me you had your first actual in-clinic day where the patients came in. So that's progress. Yeah.
It really is. And you're correct. As we discussed a little bit ago, the first full clinic, morning and afternoon, all patients in person, since probably February. We have been doing telemedicine, and telemedicine has made for some interesting developments, and I think we're going to make use of that moving forward. Out of state, out of city patients, there's certainly an advantage, but there's no substitute for seeing people in person. So it was really nice to be able to do that today, from the beginning to the end of the clinic, and have that, face-to-face contact. So.
Yeah, I think that we have all learned a lot from this pandemic. I know myself included. I used to do these video interviews at conferences, as you well know, and those have all been canceled. So thank goodness for Zoom and being able to talk to you guys. So I have a very good topic for you today, and I want to thank you, first of all, for being on our Facebook group, the Deep Sea Community, because I hear from patients, they're so happy to have the surgeons on there. So we appreciate your time and expertise on that page. And oddly enough, not oddly enough, coincidentally enough, a question came up from someone, and I thought, I haven't done a video on this. I know who I'm going to ask. And so thanks for stepping up to the plate. And this, I don't think this is one woman who wants to know this. I think there are several who would like to know, Dr. Pisano, about the process. Women come to you and they come to you with implants in currently, and then they want to transition to deep. So walk us through why women come to you for that. What's the reason? And then tell us a little bit about the procedure and recovery. I'll let you take over.
Well, those are great questions and a great overall topic. Yes, I see very frequently on Deep Sea Journey that patients are presenting on your site with problems related to an implant-based reconstruction. And the kinds of things that are brought up are very sophisticated. And as I commented on a thread within the last week or two, you have raised the bar for the dissemination of knowledge about breast reconstruction to a very, very high level, a physician level. So I want to begin by thanking you for that and bringing these issues to the attention of so many people who are really at one level seeking information, but at another level really, really hungry for information and in dire need of it. So I'm starting with a thank you for what you do, because I read these threads, I read your comments, and it's very, very impressive. It's very sophisticated, and it's enabled people to get information right away. So there's no lag time. So I want to just start with a thank you for what you've done and what you're bringing to the table. It's amazing.
That's very kind of you. I have a passion for this work because, as you know, I had my reconstruction at PRMA, and I reach out to you guys to learn more and more. So I always say it's a team effort, but I appreciate your kind words. Thank you. It's important for me for women to get the right information, and you guys follow that same model. So who better to reach out to?
Well, thank you. And thank you again for having me. So the topic at hand, many patients who have had an implant reconstruction will seek a conversion, is the word I use, from an implant-based reconstruction to a tissue-based reconstruction. Why? So I would say the two main reasons are animation deformity, and secondly, an overall sense of tightness, or what we call a contracture. So these two things, animation deformity and contracture, I put under the title mechanical problems with an implant reconstruction. And I explained to patients that an implant-based reconstruction is not like getting a breast augmentation for aesthetic reasons. You don't have the normal skin and soft tissue breast envelope over the implant to camouflage the implant. After a mastectomy, the envelope of skin that covers the implant is thinner, and therefore reveals the implant in the form of edge visibility or rippling or movement of the implant. So again, very, very early on in this discussion, these are mechanical complications or mechanical problems that have to do with the relative lack of tissue coverage over the implant. Now, I would hasten to add that many patients can and do have successful outcomes with an implant reconstruction. I'll just put that out there right up front. But the delayed reconstruction patient, the patient who's had radiation, the patient who has had a very aggressive mastectomy such that the overlying skin envelope is very thin, those patients can be setups for, again, these mechanical problems that stem from an implant-based reconstruction.
Makes
So,
sense.
yeah. So from the outset, this is who might be seeking a change from an implant-based reconstruction to tissue.
Yeah, I like your word conversion. That's a new word for me. I like that word.
Yeah.
Conversion.
Yeah, and that's what I say to patients that seek an opinion from me. What should I do? What can I do? And that's the word I use. And I say, okay, you have an implant reconstruction. It served its purpose. Maybe it didn't. Maybe it was difficult from the get-go. Maybe the implant now has kind of held the skin out to length and created a pocket that we can work with. So whatever the circumstance is, we pick up from that point and then go forward.
Yeah, because as you said, I think each case is going to be unique.
Yeah.
Yeah.
Yeah. And the other thing that I point out to patients is, and this is a cliche, this is my disclaimer, implant reconstructions are simple, but not easy. And what I mean by that is implant reconstructions are simple in their concept. You take the implant out of the package, you put it on the back table in the operating room, and then you put it in the patient. So it's simple. It's just that it's not easy to execute an implant reconstruction in a way that consistently leads to a satisfactory outcome because of the circumstances I just mentioned. The soft tissue envelope is thin. The footprint of the breast has been exceeded by the mastectomy. The quality of the soft tissue has been rendered less than satisfactory because the patient has had a radiation. So that's the part that's not easy, is dealing with all of these factors that make a good outcome difficult to achieve.
One surgeon told me once that a good, part of a good aesthetic outcome in implant reconstruction is preparing that pocket. And what they don't realize is the intricacies of what you guys have to do as microsurgeons, as plastic surgeons, to prepare that pocket. And it's the skin envelope too, like you said, but when
Well, yes, pocket control, getting control of that environment is the difficult part of executing the implant reconstruction. Now, the dermal matrix products, the Stratus, the Alloderm, the Flex HD, all of these products, have they helped? Absolutely. They help you restore some thickness to the skin envelope. They camouflage the implant surface and implant edges. No question about it. However, these dermal matrix product, you're talking about 1 millimeter to 1.5 millimeters to 2 millimeters. So it's thin. So you get some benefit early on, but over time, that dermal matrix, in my experience, it erodes, it gets thinner, and then it's as if you haven't put it in. And so again, over time, you encumber these mechanical problems, visibility of the edge of the implant, animation deformity. Now, one of the things that surgeons do to try to get more soft tissue over the implant is to put the implant under the pectoralis muscle. And I see a lot of comments on Deep Sea about this, having a DMX doctor talking about putting the implant under the muscle. Has anybody had this? Is it better to go on top of the muscle? So the patients are catching on that this is an issue. So there's a paradoxical thing that happens when you put the implant under the muscle. And that is when the muscle activates, the implant rises. Yes. I just saw a patient from Tucson, Arizona. 20 minutes ago. Works out, very fit. So I ask patients to do kind of the prayer emoji and activate the pec muscles.
Yeah.
And her implant rode all the way up to the clavicle. It doesn't go down like you think it would because the muscle's pushing it down. It rides up. So this is the baseline of, and a big part of my practice is this conversion from implant to various forms of tissue reconstruction. Each of us in our practice, as you know, we're interchangeable. We all do the same things, but we all have little niches in the practice, and this is certainly one of mine.
Yeah, yeah. So then, okay, so they come to you and they've pretty much decided, you know, I'm having mechanical issues, as you speak of, with my implant, and I've decided I want to go to deep flap now. I want to make that conversion. So
Yes.
the surgery then is, I mean, I had delayed deep, so I didn't have an implant. So tell us a little bit about the mechanics of the surgery then, Dr. Pisano.
Yeah, excellent question. So before I talk a little bit about what goes on in the operating room and a little bit of technical stuff, I want to answer the question. So why would you go to a tissue reconstruction? It's a daunting thing. It can be. It's a big operation. It's more sophisticated. Some time in the hospital, some recovery. Why would you do that? Why would somebody want to do that if they have implants in place, even though there could be issues, some discomfort or, you know, movement of the implant? So I begin by saying the benefit of autologous tissue from your body is it's living tissue, it's a permanent reconstruction, and for the overwhelming majority of patients, and you can speak to this because you've had it done and you know, tissue reconstruction patients tell us that the tissue feels like more of a part of them, not stuck on or foreign the way an implant does. And I hear this time and time again. Because the tissue incorporates, it's warm, it's soft. You don't get that paradoxical movement. And later on in our discussion, we could talk about making the flap sensate, which improves that sense of the tissue being part of you.
Yes.
So we get at, here's why you do it. This is why you take that step. The corollary to that is the day and age of a big encumbrance for the recovery for a tissue reconstruction is over, because we've learned how to make the recovery process better. So as at the beginning of this discussion, I put out a, you know, it's going to be all right. We're going to get you through this. It's not a week in the hospital like it used to be. It's 2 days. We had a patient a few weeks ago home on day 1, and we're probably going to move more to that, I predict. And the recovery is really not much longer, if any longer, than an implant recovery. And there are papers that discuss this. But suffice it to say that the day and age of a big separation of an implant reconstruction recovery to tissue is gone.
Yeah.
So that's why you do it. It's permanent, you feel better, and the recovery is really not that much longer. And it's a snapshot in time anyway. Mm-hmm. So that's why you do it. And then you eliminate these mechanical problems.
Yeah. So that's really interesting because, you know, I had mine done in 2014. So you guys were just on the edge of starting to use ARAS protocol.
Yes.
I didn't have ARAS protocol. I've done a video with your partner, Dr. Crisopolo, about this, comparing the two.
Yeah.
And so what's interesting is I didn't have pain with my recovery, but I was in hospital 5 days.
Yeah.
That's a big difference. And now when I see patients having this turnaround, it's amazing. I came up to hospital and saw one of your patients that was on AirAss, and I'm like,
Yeah.
okay, you just had surgery yesterday and you're walking and you don't have your catheter in. I'm a little bit jealous.
Yeah. Yeah.
It's great. It's great. You know, this is the
Yeah.
progress that we see
Yeah.
in reconstruction, and mine has only been 5.5 years ago.
Yeah. Yeah. ERAS has been a game changer, and we're still learning things and modifying and making adjustments, and it's getting better and better. That's why I say, somebody in the group had a patient go home on day one. They just like, I'm good and I'm leaving. What are you going to do about it? And they left. And, you know, not against medical advice, but the point is they felt well enough and were like, okay, we don't have any reason to keep you. So, so much better, you know, in that regard. Absolutely.
So then in this conversion surgery then from implants to flap, the recovery then basically is about the same as it would be for just a regular DEEP.
Oh,
right?
absolutely.
Yeah.
Yeah, absolutely. So a little bit ago, you asked what's done. So let's say a patient comes in and they've had an implant reconstruction and they have tightness or a contracture. So the first thing is the person in the group who's preparing the chest site is going to remove the implant, remove the capsule, put the muscle, the pectoralis muscle, back down in its anatomic position.
Okay.
That single-handedly makes patients feel so much better when you put the pec muscle back in its anatomic position. Because what we're going to find in the operating room is that the pec muscle usually has moved upwards. We call it window shading. The pec muscle contracts. It gets almost like a band. So we unfurl it, we stretch it out, we put it back down. And one of the reasons why the recovery is really no different than just doing a DEEP flap from the get-go is that once the pec muscle is put back in place and you don't have the implant under it, patients feel immediately better.
Oh, I can imagine.
In the recovery room. So that set of things that the person in our group is doing to prepare the chest makes patients immediately better. That big implant that's compressed by the muscle is out, the muscle's down, it's not fighting against that implant all the time. So boom, you feel better right away. Then the person harvesting the flap, and when I'm with one of my guys, I'm usually the flap harvesting guy because that's what I like to do. We're going to tailor that flap harvest to get a size or an amount of tissue that fits what we need. Usually we don't need an amount of tissue that's as big as the implant was. So we sort that out. We do our measurements. We just because we've done so many of them, we kind of know what we need. And then things just then unfold as they ordinarily would. Once we've recreated a normal circumstance in the chest, it's, you know, business as usual, and then we proceed.
Well, that part of it then sounds like, you know, what the process is for DEEP flaps. So the recovery has to be very similar then.
Absolutely. Absolutely. And so again, I sense when I read the stories, it's amazing. It's unfortunate, but it's amazing that patients endure a lot of surgeries trying to get an implant reconstruction to work, especially in the setting of radiation. So it's an expander, then the expander comes out, and then it's put in, and the implant goes in, and then that gets replaced. And so I read time and time again, and certainly when I have my clinics and I'm seeing patients like this, it's a common theme. So once again we eliminate that issue, the rest of it just kind of proceeds as usual. The part that may not be usual, that is a little extraordinary, is in the patient who's had radiation or the patient who has lymphedema. So we're doing extra work to recreate the proper footprint, or we're doing a lymph node transfer that's going to be done in conjunction to reduce or eliminate lymphedema. So that's what I did yesterday with Nistala in my group, Chet Nistala. So bilateral delayed, one side lymphedema, so we transplanted lymph nodes. Just in a given week, somebody in the group is going to be doing that in addition to removing the implants that are there, or the expanders if the implant reconstruction was never completed. So.
Well, I tell you, you've given us some wonderful information today. And I think that this conversation,
my pleasure.
Yeah, I think what it's going to do is give women hope because of the details that you've given us, Dr. Pisano. Give them hope in that, as you said, there are so many successful implant reconstructions that women don't
Absolutely.
have. Oh, yeah. But when women do have issues and they have to think, oh dear, now I've got to face more surgery. I think what you've done through this conversation is, given the listeners hope, knowing that it's a solvable problem. And
absolutely.
Yes. And I do encourage anyone who is listening, this is a great group that I'm talking to. Dr. Pisano and his group is a great group. There are others across the country, but it's so important to do your homework and to ask the questions. So we appreciate all of your information today and for joining us.
Oh, it's my honor, my pleasure to be of service.
Yeah.
Anytime. And I try to chime in as often as I can on the Facebook and just put something out there. And as I've said many times, so many good comments on this thread. No wrong answers here. You'll see that time and time again from me, because I'm there to just kind of shore things up, have patients able to gain access to information. And I'll echo what you just said. Lots of good microsurgeons out there, and we know all of them, and they know us. We all know each other. Yeah. So if they go see somebody else and it's a name I recognize, all good. It's a tight circle, and we're a band of brothers and sisters on your site and in the world of microsurgery. We all know who we are. It doesn't have to be me, but my role is first and foremost to allow people to have access, because as you know, many patients, they don't know all their options, or they're in a community where there aren't a full complement of options. I'm facing a window. I went to high school about 1.5 miles that way, and I grew up about 1.5 miles that way. So the practice is in San Antonio. I'm in the middle of where I grew up. It could have been in Chicago or New York or LA or something, but I wanted to come home. So I want patients to know they can find a home. They can find a place to get to a point of comfort and confidence. And they're always able to get information in whatever form on your site, from our website, or somebody else. There are great microsurgeons out there, our colleagues. So that's my summation and thank you, and just what I hope to bring to people.
Well, I appreciate everything you said, and it's the sharing of the information. So grateful to you guys for that. So thank you for joining us today. And for those who are listening, if you have questions or comments on this video, or you have other topics you'd like us to cover, please let us know. Dr. Pisano, stay safe, and thanks for joining us today.
You too, my pleasure. And I look forward to seeing you again in person at a meeting or on a visit. It'll be wonderful when we can do that.
Oh my gosh, I'm so ready for that. I'm so ready, and I look forward to it too.
All right.
Take care.
All the best. Thank you.
All right.